morning, ladies and gentlemen. It is my pleasure to introduce to you today in the morning my PhD topic, maxillofacial surgery in cleft lip and palate patients. My name is Alexander Schulze Wenning. I'm currently a second-year PhD student, as well as from next September on a fifth year, so last year, dentistry student here at Semmelweis University. My vision is that no cleft baby left untreated worldwide. So my specific goal was, and I especially say was, this may be a bit confusing for you, but you will later see why. Initially, it was a comparison between one-stage and two-stage palatoplasty, comparing maxillofacial growth and speech development in unilateral and bilateral cleft lip and palate patients. This manuscript was submitted to the Journal of Cranio-Maxillofacial Surgery, the best journal for maxillofacial surgery. And luckily, I say so, it was rejected, because this gave us the opportunity to amend our manuscript and change some intrinsic weaknesses of our manuscript and then redo it and to come up with some much better strategy. So our current goals are those 6. This might seem a bit frightening initially, because why 6? It is a lot. So very clear, the first 3 as well as the last 3 are basically the same, investigating a bit of a different outcome. For the first 3, we investigate the maxillofacial growth, and for the last 3, the speech development. So the first 3 is just a comparison between one-stage and two-stage palatoplasty. The second specific goal is to determine the best and optimal timing for palatoplasty, and the third one is to determine the optimal technique for the palatoplasty. The same accounts for the last 3, but instead of maxillofacial, we look at the speech development. So let's start with our first 3 specific goals. Comparing one-stage and two-stage palatoplasty in uni and bilateral cleft lip and palate patients for maxillofacial growth. Just a general background for cleft lip and palate. Cleft lip and palate is the most common oral facial deformity with a worldwide incidence of roughly 1 in 600 live births, and much, much higher even in Southeast Asian countries, up to 1 in 250. It results from embryologically non-fusion of the alveolus, lip, soft and hard palate. There are many different types of cleft lip and palate. Our study will concern itself with the unilateral and bilateral cleft lip and palate. One may ask, why do we want to investigate this? There's nothing really new about it, but there are no universal guidelines out there how to approach this deformity surgically. The Eurocleft study has shown that 201 different cleft teams operate in 194 different protocols. So it's a huge diversity in the surgical techniques used. Very quickly and easy to say, one-stage surgery, soft and hard palate are operated together in one surgery, and the two-stage surgery means soft and hard palate are operated in 2 different surgeries, either soft first or hard first or vice versa, both possible. Why would someone do two-stage if also one-stage is possible? Because it is assumed that two-stage palatoplasty results in a better maxillofacial development. That's why we set out to investigate if patients actually benefit more from one-stage or two-stage palatoplasty. That's also how our clinical question came. Here we can see our question framework, the PICO framework. Population, as I said, is a uni and bilateral cleft lip and palate. We look at the intervention and the comparator, intervention one-stage palatoplasty, and we compare it to two-stage palatoplasty. Our outcomes are cephalometric outcomes. Cephalometry, especially in this case, lateral cephalometry. This means it's an X-ray of the side of the head and then a tracing of the skeletal structure of those kids and growing patients. Here you see some maybe frightening abbreviations, SNA, SNB. No worries, in the next few slides you will absolutely understand what they mean. Our hypothesis is that one-stage palatoplasty is at least as good as two-stage palatoplasty. Because if this would be true, one could double the amount of surgeries. This is especially important in third world countries or in developing countries where not yet every child can get a surgery due to the inherent nature that there are not so many surgeons, and also the money. And of course, also one could decrease the anesthesia exposure for these young patients. This was our systematic search done in 3 databases. This is now our current status for our amended manuscript 1. We are again rewriting the manuscript with our final results now. And there was a bit of a lag in between because there was an exam period for me as well. So SNA, what does it mean? Very quick and easy. We have the cellar, that's S, N nasion, and A is the A point, the most concave point of the maxilla. And these 3 together constitute a point angle, which we can calculate, and then we see now 2 forest plots. On the left side, for the audience, we'll have the forest plot, one-arm forest plot for two-stage palatoplasty. On the right stage, one-stage palatoplasty. Here we can see the overall mean after two-stage and one-stage. First, I would like to say that these are subgrouped in unilateral and bilateral cleft lip and palate. So, as a rule of thumb and also supported by the Cochrane Handbook for Systematic Reviews and Meta-Analysis, one can compare the confidence intervals, and if there are overlapping confidence intervals, one may say that there is no statistically significant differences. Also looking at the size difference or the angle difference, we can say that there is no clinical significant difference. This also accounts for the bilateral cleft lip and palate. Now, S and B. We already know Sella and Nasion. Now the next point is the B point. So that is the most concave point of the mandible. Here again, all of these three constitute a point angle together and our beautiful forest plots. Again, 2-stage, 1-stage, subgrouped by uni and bilateral cleft lip and palate. Again, here we can see that there is no statistical as well as no clinical significance between 1-stage and 2-stage palatoplasty for unilateral and for bilateral cleft lip and palate. Our last parameter outcome, which I would like to show you, is the A and B. There are more, but due to the constraint of time, these are the only ones I will show to you. Again, all of them we know. A point, Nasion, and B point. Them three together also a point angle, but a much narrower angle, so it's pretty hard to see. The optimum angle here is about 2 degrees. Again, we have two forest plots showing that there is no statistical as well clinical significance between both of them. And this is actually, you might say, oh, there's no significant difference, but this is actually great, because if 2-stage is not significantly better than 1-stage, one might advocate the 1-stage palatoplasty. This is also our conclusion. Maxillofacial development does not substantially be different between 1-stage and 2-stage palatoplasty. That's why 1-stage palatoplasty or 1-stage surgery is the operation of choice for most cases. What would be really amazing for future research is that in the articles which are presented, they a very detailed cleft description with the width is included, because then we could subgroup for the width and then maybe see what type of, not only unilateral, but what is the size of the cleft, which surgical technique to use, or 1-stage or 2-stage. So this is up to date, the most comprehensive study, and we had, of course, a very strict accordance to the PRISMA guideline. Unfortunately, but due to the nature of the disease, there were only retrospective or some also cross-sectional studies included. So, for our second study, determining the optimal timing for palatoplasty. Here we can see, just a quick up, there is a huge variety in when to start and how to start the palatoplasty, from as early as 3 months for the first surgery or 12 months for 1-stage, up to 94 months, so roughly 7 years and about 8-9 months until the last type of surgery. There might be differences as well, but these are the numbers we included in our study and all them we were able to find. So, why is there such a huge difference? It is assumed that the later the hard palate surgery, the better the maxillofacial development. Why? Because early hard palate closure will lead to early scarring, which then will lead to a bigger increased growth inhibition. That's why we set out to investigate if patients benefit more from delayed palatoplasty. This was our systematic search done. Again, the question framework is basically everything the same. Instead of PICO, we have a PFO, no intervention in comparator, but a factor. Our factor is timing of palatoplasty. So, and with this, of course, increasing patient satisfaction. As a quick recap, we have the S and A angle. And now bear with me, these are just preliminary plots. This is an explorative plot, preliminary data, just to show the general trends. And we can see a great general trend here in the 1-stage surgery, seeing that the later the palatoplasty is done, the larger the angle is. So, yes, this somewhat also supports our hypothesis. For 2-stage palatoplasty, for soft palate surgery, as well as for hard palate surgery, here we can see there is no trend in the timing of the soft palate surgery, but this is clinically also very logical. Of course, that the timing of the soft palate should not influence the maxillar growth. For the hard palate surgery in 2-stage, we might see some trend, but I'm really eagerly looking forward for our final plots there and what then the real answer will be. So this is how far we are with our second study. Regarding our third study, the determining optimal operation technique. Here, again, the same. The only difference is the factor is now different techniques of palatoplasty. And again, systematic search is done with the search key. This is how far we are here. Quickly regarding our last 3 specific goals, analyzing the speech development. Everything is the same here, 4, 5, 6, as it was 1, 2, 3. But here the difference now is the outcome. We don't look at cephalometric outcomes, we look at speech development, primary velopharyngeal insufficiency, secondary nasalence, as well as audible nasal air leakage. The same clinical implications do include this one. As a quick background, velopharyngeal insufficiency is the incompetency of your velum, your soft palate, to properly close against the pharynx. So it might happen that air escapes through the nose while speech. Not only the soft palate, but also the hard palate is very important for proper speech development because your tongue needs to learn and interact with your hard palate. That's why we set out to investigate what's the best timing, what's the best technique for this palatoplasty. This is our systematic search done. We haven't done the selection, but we checked for topic feasibility and did a Prospero registration. Just generally, and now to wrap up everything, additional activities, and a great thanks go out to my supervisor and team, of course, and we have been in Marseille at the IADR conference to present our results. Yes. With the words of Nietzsche, I would like to thank you for your attention. There will always be rocks in the road ahead of us. There will be stumbling blocks or stepping stones. It all depends on how you use them. Thank you very much for your attention.
Were there any studies to compare first and two-stage surgeries in your first project?
Yes, indeed.
You did not compare them directly.
So there are many reasons. Of course, we have many more plots. Due to the constraint of time, I couldn't show all of them. We have plots, for example, comparing in one forest plot, one stage with two-stage palatoplasty, but also due to it doesn't really make sense to make a mean difference between one-stage and two-stage palatoplasty because it is not about what is the difference. It is what approaches 82 degrees, which is, let's say, for the SNA angle, which approaches the 82 degrees in a more closer way. That's why the mean difference wouldn't make sense. But these plots exist as well, probably then for the supplementary material. Thank you, Andrea.
So first of all, Professor Vargas told us don't hesitate to take stupid questions. But as far I know, SNA, SNB is dealing with the sagittal differences. How about the horizontal one? My second question is about the bias. So were there any additional orthodontic analysis of the cephalogram, and how were the ortho treatments before, after? So how comparable are the data you got and extracted from the literature?
Regarding your first question, of course, the horizontal aspects are important as well. But we believe that the sagittal aspects, especially for the palatoplasty, are of more crucial importance, since the palatoplasty often leads to a retrognatic maxilla, and the retrognatic maxilla is then portrayed in the SNA angle most often, and also then, of course, in the A and B. And also these were the results which were most commonly presented in our in the studies we included. So there we had the biggest amount of literature for this. And regarding your second question, the bias, yes, indeed, there were differences. Most often, every population in one study was treated in the same way. Not always, but most often. So that early infant orthopedics and so on are different, like the HOTS device as well. In our data extraction, we did indicate it. And we're also looking forward later on to do a multivariant model, which includes these types of pre-orthopedics early on. But this will also then be more investigated. And yes, of course, this constitutes a bias, and this leads to a heterogeneity in itself in the studies. But later on in the manuscript, you will see as well, we have next to the forest plots the risk of bias assessment. And if there was differences, the bias is, of course, upgraded there.
I don't know if can be important, but maybe as a type of approaches is also important. For example, if patients are operated by an pediatric surgeon or a maxillofacial surgeon, I think the approaches are a little bit different. And I don't know, maybe as onset of the surgical treatment, it's also very important. Maybe you can discuss something about this.
Yes, of course, it is very important what operation technique is used. This will be our third study, investigating exactly the technique. For example, the very, let's say, old school method of the Langenbeck technique or the full-node Doppler closing Z-plasty. But all of them, they will be in our third study, and then we will subgroup for the different techniques. Regarding the surgeons, in every paper, it never really specified, or in some actually did specify what type of surgeon, if it was a maxillofacial surgeon. No paper said it was a pediatric surgeon. But what some papers do say, not all, if it was always the same surgeon, or sometimes if it were a different surgeon, it do say. And of course, this was incorporated in our risk of bias assessment as well. And also, not only this, but also the proficiency of the surgeon. If they say he was just a freshly specialized surgeon or already a surgeon with experience for more than 20 years, of course, this also goes into our bias assessment there. Did I answer all your questions in this regard?
Thank you. So I know this problem because in our family was a similar case. So I think the horizontal component of this problem and the surgical method is also problematic. Do you find any papers about these horizontal aspects?
Since we set out to investigate the lateral cephalometry, there were some also including horizontal, but we didn't do a systematic search for the horizontal. But I will have a further discussion with our clinical supervisor about the importance of the horizontal. And then I think it's a great idea for further specific goals to not only investigate the sagittal, but also then the horizontal aspects of change.
Again, based on your studies, what do you think the ideal time for performing these operations is?
So one first needs to consider, do we do one stage or two stage palatoplasty, right?
Well, I think we prefer the one stage. Do we?
There is a slight larger increase there's a slightly bigger SNA angle in the two-stage palatoplasty, even though it doesn't constitute clinical as well as statistical significance. That's why one could say, especially in regards of the decreased anesthesia exposure, that one stage should be recommended, because I think especially for young growing patients and babies, anesthesia exposure is a really important topic. Regarding your question in the timing, since this is only explorative, this may still change, but so far I would say a delayed palatoplasty is advantageous. But the question here is as well, how far can you delay if you have a one-stage palatoplasty, right? Two-stage you can delay pretty much, especially the hard palate surgery aspect, but in a one-stage surgery, this needs to be still quite early on, because you can't leave the complete cleft open. But also, there is always, every case needs to be considered individually, depending on the cleft, on the width of the cleft and the size of the cleft as well. Yeah, but I would rather say,
on average, what is the optimal time? What is the optimal age?
I would say for one stage, about 1.5 years to 2 years of age.
Thank you. And my second question is about your manuscript. So I understood we had to withdraw the first one.
It was rejected.
Oh yeah.
Yes.
Okay. It was rejected, or yeah. And now we try to refine the whole thing.
Yes.
What is the planned time for submitting the?
Actually, we are really far, as you may have seen in the first 3 progress slides. How far we are. We have the data completely. The lucky thing about this is that for the first 3 specific goals, the systematic search and data extraction is all the same. Because from the same search key, I can find data about one stage or two stage. I could find data about when the surgery was done, as well I could find data on what type of surgery was done. And the data extraction for all of them is already done. And since we have already written the manuscript for the first time, it's just a bit of changing the wording and focusing on one stage and two stage for the first one, focusing on the timing and focusing on the surgery technique. Everything is planned to be done by end of next month and submitted by this summer, August. Yeah.
To the same journal?
Pardon?
To the
same journal, yes. Same journal. We plan on doing it as a series, like a comparison of one stage, two stage palatoplasty, 1, 2, and 3. I've seen this many times, also especially in the Journal of Cranio-Maxillofacial Surgery. There was for the Eurocleft. It was also then done in many series. There was a discussion back and forth if this is good or not, but I strongly believe this is much better, because we can go in the discussion much more in depth, really explaining the difference between one stage and two stage. If we cram everything into one paper, I think much value could be lost.
Thank you very much.
Why do you think that this is just an exploratory relationship here?
Because we don't have yet all the data, right? And there is, as we discussed with the statistics team, there will be more in-detailed analysis done. And that's why it's so far just an explorative plot, and due to the preliminary data we have. But I think the trend will probably stay the same. But of course, I can't say it until we have the final results.
Will you have any other variables to include in the model?
Yes, so there are many more variables as well, which we will see how much it is possible with a multivariable model to even include much more. So not only the timing, but also the technique, the proficiency of the surgeon. So to try to approach this in a multivariable model.